Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to today's webinar titled Finding Value in Linking Real-World Data with Social Determinants of Health, featuring two experts who will highlight the importance of SDOH and discuss examples of how claims data and electronic medical records linked with SDOH can inform use cases. I'd like to take a moment to thank the sponsor of today's event, Magnolia Market Access, for making it all possible. I now want to introduce the panelists participating in today's session. Dr. Pamela Landsman-Blumberg is a Senior Vice President of Real-World Evidence and HEOR Strategy at Magnolia Market Access and is an industry-recognized subject matter expert in real-world data evaluation and real-world evidence generation. Our second speaker is Dr. Rick Chapman, Chief Science Officer of Research at Innovation and Value Initiative, a nonprofit advancing the science, practice, and use of value assessment. And now, without further delay, I am pleased to have Pam join me. Hi, thanks for being here
Hi.
today. Please take it away.
All right. Thank you, Sydney, and thank you everyone for joining Rick and I today. We're really excited to be presenting this information and some of our findings to you. Just a brief introduction to Magnolia Market Access. We are a medical knowledge group company. So we are part of a series of companies that are sort of in the areas of medical communications, agency work, primary market research, analytics. We are a full service HEOR market access consultancy. So we actually are able to draw on the expertise across the medical knowledge group companies, which is extremely helpful, and we can pull them in at any time needed. So let's get into it. So just some level setting. You'll hear a lot of terms. You hear health disparity, health equity, social determinants of health. How do they all fit together? So on this slide, I kind of try to explain the flow. So according to the WHO, a health disparity is an avoidable and unfair difference in health status, incidence, prevalence, mortality, or burden of disease between specific segments of the population. So health disparities have very broad consequences for the economy and quality of life. And really within the US account for $42 billion in lost productivity per year. And that does not include the economic losses due to premature death. Now, so what happens is a health disparity can then lead to health inequity. So health equity broadens disparities concept to ask, why are some populations at greater risk of diseases and preventable deaths than others? So inequities in the US cost about $1,000 per person today. And by 2040, it's going to triple to $3,000 per person, or $1 trillion in higher healthcare spending, lost productivity, and premature death. So in order to answer questions around what can we do about inequities, you need to explore the root causes or the social determinants of health that contribute to these inequities. So social determinants of health are the conditions in which people are born, grow, live, work, and age. And it's been estimated that these can drive up to as much as 60 to 80% of health outcomes. So currently today, if you think about it, and those of us who are working in epidemiology and HEOR, health services research, what we are explaining is only a fraction of what is driving health outcomes in different populations of patients. So I'm going to be presenting a lot of the analyses that have been done. So what were the objectives of the analyses? So first, internally, we have some data sources which I'll go through, but we really wanted to quantify the overlap of in-house consumer social determinants of health data with EMR data, as well as closed claims databases that we have available. Then we wanted to look at the distribution of different social determinants of health measures from the consumer data with ICD-10, with those data, as well as some ICD-10 Z codes, which you may or may not be familiar with. I'll discuss those a little later, that are available in the closed claims in the EMR. And we wanted to look at six different diseases, and we wanted a good cross-section of diseases and populations that they would represent. So we looked at HIV, chronic kidney disease, heart failure, type 1 and 2 diabetes, and metastatic prostate cancer. And then third, we wanted to identify what measures were available for inclusion into real-world data analyses to support product value props, economic models, and other evidence generation activities that we would be doing in conjunction with our clients. So a little bit of an overview. We have a data center of excellence, and I'm actually going to be focusing primarily on the three data sources at the top: the closed claims, electronic health records, and social determinants of health. We have other data sources as well. Everything is HIPAA compliant. And actually, the closed claims, the EHR, the SDOH, and our open claims already are linkable. And we have a unique anonymized patient identifier that is common across the 4 databases, so that we can link those and look at people who are in common in different combinations of databases. And we can also link these through DataVant tokens to external data sources, which we have also been doing because we already have those tokens available. So our closed claims are commercial closed claims. They are payer sourced predominantly from employer-sponsored plans. Then we have our electronic health records, which are providers who are based in the community setting. It is primary care as well as specialty data. And then, as I mentioned, are social determinants of health data that captures information on individual lifestyle factors, social and community networks, as well as general information about a particular person's surroundings and environment in which they live. So again, to level set, we have the counts of unique patients, at least for the most recent data, 2022, that are available for linking. We have 189 million people in the social determinants of health. There may be people who are duplicated for a number of reasons. Tokenization is a discussion for another day. In the closed claims diagnosis table, we're not using the enrollment table because we're looking at people with specific conditions, diagnosed conditions. So there's 30 million there. And in the problems table of the EMR, which captures diagnoses, there's 14.7 million. So in order to identify patients with the different disease states, for the closed claims, we use the ICD-10 diagnosis codes. And then in the EMR, we used ICD-9, ICD-10, and SNOMED, which are available. ICD-9, one is our data does go back to 2015. But also, there are actually some providers that I haven't converted yet. So you will still find ICD-9 codes for some patients in electronic medical records. So we then matched each of those individuals, and people could be in more than one disease group, where they're matched to the SDOH tables using that unique patient identifier. And then those that were in both either the closed claims and the SDOH, or the EMR and the SDOH, were retained for analysis. And the diagnosis we looked at as of everything we had as of December 31st, 2021. So here's information about our overlaps. The rows are the different disease states that we looked at, and the columns will tell you about if it was the closed claims or the EMR, the number of patients that we found that overlap, and what that proportion of overlap is. So on average, in the claims, the closed claims, we found an overlap of 36% of our identified patient population. And in the EMR, it was approximately 24% overlap. And so you can see for, let's say, chronic kidney disease, stage 1 or stage 2, which is the second row, there were 370,000, patients who had some evidence of stage 1 or stage 2, early stage CKD. There was an overlap of 134,000 of those patients, which is a percentage of 36.1%. And you can see it differs for the different conditions. So in closed claims, we ranged from about 30% in the metastatic prostate cancer to 40% of the HIV population. And then in the EMR, 19% in the prostate cancer to 34% in the HIV. So sort of that low and that high was pretty consistent across the two clinical databases. So what are the ages of the populations? So here we have the mean and the standard deviation for the age of the population. And you will see that, so the youngest are those with type 1 diabetes. The highest are those with metastatic prostate cancer. Age is capped at 90 years of age, actually in both the clinical databases and the social determinants of health. That is not uncommon. Some databases may cap at 85. So there is a cap on age. There is there's no lower limit. But you may notice in every case, the EMR patients are much older than those in the closed claims. So you may ask why. So this is where it's very important to remember where the underlying population is sourced from. So the closed claims are the enrollees in employer-sponsored health plans. So automatically, it's going to be the employed person, possibly a spouse or a domestic partner, and any other dependents that may be in the home, usually children. So most people are going to retire around age 65. Some of these employers do provide supplemental retiree coverage. So we do have some patients who are older than 65. Not every employer offers those. And so they're going to tend to be on the younger side. And then the EMR, remember, it's community-based. It's everybody in the community that could have access to that provider. So, in the US, think about the US distribution of age, and we have our baby boomers, such as myself. So you're going to have probably an average population that is going to be older. The other question you might ask is, why is the mean age for type 1 diabetes 37 and 47? This actually has to do with the SDOH data. So it is consumer data, is where our data is sourced from. It is not captured on people younger than 18. And in part, also, you cannot advertise in the US. You can't have any advertisements or really target younger people in your for your consumer products. So in this particular analysis, we do not have younger type 1 diabetes patients. There are ways to actually include social determinants of health for younger patients, which we might get to in the Q&A a little later. So what's the racial distribution of these populations? So here you will see for each row, each condition, the top row is the commercial claims overlap, and the second is the EMR overlap. So there are very similar racial distributions for the closed claims and the EMR for the CKD stages 3 and 4, type 2 diabetes, and HIV. However, the EMR with population that's overlapped with SDH has greater diversity than the closed claims for the early stages of CKD, where you have a greater proportion of Hispanics. So you can see here it's about 9.1% versus 17.4%. A little more obvious in the advanced CKD, where it's actually a higher proportion of Black and type 1 diabetes, higher Blacks and Hispanics, and actually prostate cancer, all the other racial groups aside from white. So again, thinking about the underlying distributions of what patients are being seen you're seeing in the closed claims and you're seeing in the EMR. So next we looked at some information having to do with the household. So we looked at marital status of a patient, the household size, and then do children reside in the home. You can see marital status in the upper left is pretty similar between the two data sources. On the right in the table is the average household size. Again, some differences you may see have to do with the disease state, and then the age think back to the ages of the populations in the closed claims and the EMR, and that explains some of those differences you're seeing there. And then households residing with children. So we see a few differences here as well. What we wanted to do is try to get some measure of if someone would have a caregiver or some help at home to manage their disease. So we can look at these three individually, and they're informative on their own, but they're much more informative if you can create a composite measure of the three. And we did that by breaking people into, it's actually 5 mutually exclusive groups. So we have those who are age 65 and living alone, down to, and you can see the other married, living with and without children, or single living with and without children. So this, again, helps you identify where someone might have a caregiver, at least in the home. You'll see the HIV patients are much more likely to be single, living in a household without children. It's 55% in the closed claims, and overlap, and 47% in the EMR overlap. Whereas in heart failure and metastatic prostate cancer, where you have older patients, you can see that compared to the other conditions we looked at, there is a higher proportion of people who are 65 and living alone. Another composite indicator that we created was we looked at the interaction between some of the economic indicators that are available. So we did have 2 economic indicators available among, there were several, but we looked at these 2. One is household income, and another is called an economic stability indicator. The economic stability indicator it may proxy credit scores, but it's not built on credit data. But you can see here sort of it ranges from about 1 as the most stable to 30, the least stable, and it does somewhat approximate credit scores. So when we looked at the data, regardless of the source of the clinical data, metastatic prostate cancer had the highest and HIV patients had the lowest of the economic stability. We then grouped this based on a set of scores that categorize people as high prime, near prime, subprime. So what terms you might get and interest rate you might get on a loan. And while that indicator, the economic stability indicator and income are strongly correlated, we did see that across the diseases, about 25 to 40% of patients had, in the closed claims, had incomes above the US median of $75,000 a year, but their ESI values place them in the subprime group. And we have observed a similar phenomenon in the EMR, overlapped with the SDOH, shifted a little bit with higher proportions that fell into this group. So therefore, despite a subpopulation of people with higher incomes, these households may be classified as less economically stable. They may have less cash available to spend on things such as healthcare, healthy behaviors, etc. So some additional, one more point to that is that what you would want to do is, again, you may not want to, if you could include these as individual factors within, say, an economic model or an outcomes model, you would definitely want to include their interaction within that model, because that's going to give you a lot more information, explanatory information, than each one on its own. Some additional measures that we looked at, but we're not presenting. There's information on education level, occupation, home ownership, do they exercise, is there an infant, and something called house upscale living. And that looks at things such as, do you travel out of the country? Do you go to art museums? Do you frequent the theater? So you have, I'll say, some more disposable income on hand to to participate in some other activities. So that all looked at the social determinants of health data. Well, what about Z codes? So Z codes are what are termed reason codes. They're ICD-10-CM, so their availability began in October of 2015. They are non-reimbursable, non-medical factors that may influence a patient's health status. So you may have used them for things like smoking status, family history of disease. There's been slow adoption of these codes, but it really has been increasing as providers better understand the documentation requirements and the benefits of having this information. So, and currently some state Medicaid programs and other payers are requesting providers include Z codes, and it may actually impact patient eligibility for benefits that are related to health equity. And Rick will discuss several of those in a few moments. So the ones that have sort of fall under social determinants of health are these codes Z55 through Z65. And you can see they do get into more granularity, some of which you can see on the right, but they do look at things such as education and literacy, employment, occupational exposure to risk factors, physical, environmental factors, etc. There are additional Z codes you might want to consider that don't fall under social determinants of health, and these are Z72 and Z74. So Z72 are problems related to lifestyle, So you can see things such as inappropriate diet and eating habits, high-risk sexual behaviors, inadequate sleep. On the right, Z74 are those related to care provider dependency. So someone's confined to a bed, they need assistance for personal care. They need assistance, but at the home, but there's no one there in the home. So you can see how these do sort of map to those consumer social determinants of health that we looked at. So when we look at the Z codes, just to get an idea of those Z codes that I just presented, what proportion of patients actually have these recorded in the claims or the EMR, again, that are also have that overlap. And you can see they are much more prevalent in the claims than in the EMR. And again, why? As I said, a lot of payers are requiring them. They're non-reimbursable, but how will payers know if physicians are capturing the information unless they're included on a claim? And you can see for some factors, there's a high proportion of patients that have this information. And when we looked at specifics, I know there's a lot of numbers here, but there's some things to consider in that the absence of a Z code is not the same as the absence of that factor. So although you may have 7% of patients with advanced CKD are noted as tobacco users, it does not mean that the other 93% do not use tobacco. So, but you can see while the percentages may be low, for some of these, the sample sizes are quite high. That will allow you to conduct subset analyses, which can be just as informative as if you had sort of the yes and the no and could include that in a model or in your analysis in some other way. You also could combine some of this information with the SDOH data to fill in some of the missing data. So as I said, the information about whether they live alone, whether they have some other of the things around personal care and behaviors. So Z codes, very helpful and informative as well, again, more for subset analyses. So just some take-home messages before I turn this over to Rick. So most current studies of SDOH data and health equity actually still focus on age, sex, and race. If you look at whether you get table of contents reports or you're looking at for this information on specific disease states you're interested in, these three factors are still the most common that are evaluating, probably the most common available without doing some sort of linkage. SDOH measures are available via Z codes. And you can link consumer data. There's other sources of SDOH data out there. You can link them with claims or EMR and provide insights into disease-specific patient cohorts beyond these standard demographic characteristics that are focused on most often. It's not all about the percentage of overlap, as you saw, as the number of patients linked or the number of patients with a Z code that can allow for informative subset analyses. You want to determine if composite measures can be derived that will provide deeper insights than the factors individually. And as with any analysis of real-world data, you really need to understand the underlying population of both the enrollees and the patients, enrollees for claims or the patients, who they represent in order to put your findings into the correct context. And with that, I thank you very much. My email, you have my email address, and which you can always reach me at. And with this, I'm going to turn it over to Rick. Rick, take it away.
Thank you, Pam. And thanks everybody for joining us today. I'm going to talk a little bit about what are the different ways we could use this type of data now that we've got it in place, and that Pam has shown us, the overlap between SDOH data and EMR and claims data, and some of the things that we can look at when we overlap those two. I want to talk about some of the ways that different stakeholders might use that type of data and those types of analyses for various purposes going forward. But I wanted to stop first and just point out, when I first started in health economics and outcomes research, the idea of putting claims and EMR data together was kind of our holy grail. We were like, if we could just put those together, we would have a much more complete picture of what's going on with patients. And I don't think anybody even really had SDOH data on their radar, at least not a lot of folks. And so I think it's very exciting for a data nerd like me to be able to see that we're going to have this type of data to use and the different types of insights that it can provide for various stakeholders. So first I'll talk about some of the value that this data might have for people who are doing health economics and outcomes research. One thing that I think about first is looking at treatment pathways, and do people with different types of social determinants of health end up going down different treatment pathways, and what are some of the outcomes that come from that? I think we can also, when we're doing these types of analyses, make sure that we're getting representative data samples that represent the diversity of the heterogeneity of patients who are out there, or at least that we know when we're not reflecting the heterogeneity of patients out there and what we can do about it. I think it can help to fill in some key missing elements that we often don't have, like things around heterogeneity, complexity of people's environments, and how that can impact treatments and access to treatments. And I think access to care is really one of the big areas where this could come in really useful, to really look at how do the social determinants of health influence access to care, and are there interventions we could make that might increase access to care by addressing some of those social determinants. I think also, one of the things we should be looking at is, are interventions being constrained in terms of their effectiveness? So we often see that the efficacy that we see in randomized controlled trials doesn't carry over into effectiveness in the real world. And that could be because these social determinants are constraining the impact we're getting from those. And then finally, I think just, descriptively, it's interesting to be able to look across different payers, different regions, in different states in the country, and see, how do social determinants interact with different conditions and treatments in terms of incidence and prevalence. How does that vary across different groups? How does it impact severity of disease and access to treatments, as I was just mentioning? What are the outcomes that are influenced by SDOH, and can we change those outcomes by addressing some of these issues? And then finally, satisfaction and trust in healthcare systems and how that might vary. And I think all of these issues are things we should have been paying attention to a long time ago. But I think, the COVID-19 pandemic and some of the other things that have been going on in our society have really opened our eyes to the fact that we haven't really been paying attention to these issues and haven't really had much, insight into what's going on with them because of the lack of data or analyses. I think this type of data can also be helpful for those who are doing health technology assessment, which is increasing in use in the U.S. Market, and can help inform economic models that are part of the health technology assessment. For one thing, I think it can help identify relevant patient subgroups that we should be consulting when we're thinking about how to do these types of assessments. What's important to patients and what are they looking for may be very different for people at different parts of the socioeconomic spectrum. And so being able to identify the right people to talk to get that information is very important. And that type of information can also inform subgroup analyses to look at, are there differences in how valuable or the outcomes that people may be getting who have different social determinants of health. And importantly, I think it can also point out where we don't have good information around different subgroups that could have big impacts on the outcomes and the value of different treatments. And I think those types of data and analyses could then feed into what we're calling equity-informed health technology assessment, which is, how do we make sure that health technology assessment is reflecting and measuring the impact of interventions on equity and health disparities? And are there things we can do to address some of the disparities we see there? An example of this is a relatively new method, at least in the US, distributional cost effectiveness analysis, which really looks at, for people with different socioeconomic circumstances, what can we say about the impact of a new treatment or new intervention on those different populations? And so, for example, you might say there's a new treatment that's coming along, which is very revolutionary and is really going to help patients. But because of its expense, we know there are going to be access issues. And is that access going to be differential across the socioeconomic scale? And is there the potential that even though this is a great treatment that is going to help patients, it could actually widen disparities in access if there are those types of issues? And so we could think about, how should we be thinking about that? And should we be doing things to alleviate those types of access issues? As I said before, we can use this to think about, if a healthcare intervention is not having the impacts that we thought it would, is this because of issues with the intervention itself, or is it social determinants of health that are causing some of the constraints here? And that could lead us to address those to make sure that the intervention reaches its full potential. Access issues I mentioned, and how we can address those. One of the things that we're interested in looking at IVI is, can we tailor interventions to address some of these social determinants of health and have bigger impacts on outcomes and really achieve the full potential of interventions by removing some of those barriers to getting that care. And then I think overall, what it can really help with health technology assessment is to make sure that we're aware of where those gaps are, where we don't have subgroup analyses on certain important subgroups, where we don't have data that is representative from clinical trials, and how do we highlight those data gaps and think about research questions to fill those, rather than building models to the data and sort of sweeping these gaps under the rug and saying that we can't really say anything about them. And then I think it's also useful for those who are thinking about benefit design or different payment models. And I think we've seen this a lot recently. Coverage that's trying to tailor intervention to patients' needs, so that, for example, if they're patients with no caregiver support, healthcare providers can try to make some provisions for that, rather than patients having to go home on their own. We've also seen state Medicaid offices which have put in place requirements that patients get travel vouchers so that they can get to their appointments. That access to appointments is no good if you don't have a way to get to them. And we're also seeing programs now that are trying to connect patients who have certain needs to programs that can provide some of these needs, such as housing or food in areas that are food deserts. And we're also seeing it being used in some cases for payment risk adjustment, so that we can try to target funding and payment to areas that we know have the greatest need. We know this is going to be easier for some payment models than others, like a value-based payment arrangements. It's going to be easier than it will be for, say, fee-for-service. And there is some controversy around this. There is some concern by some folks that if you do this risk adjustment, you're kind of letting people off the hook, holding them to a lower standard if they have certain types of populations. And so, this has to be done in a very thoughtful way to ensure that we're not doing that we're really trying to raise the level for everybody. And then I think there are also uses for this type of data in broader policy analyses. I know a lot of people are concerned about the Inflation Reduction Act right now and some of the impacts it's going to have. And there's a lot of uncertainty about how that's going to be put into place. A lot of details that still have to be worked out. But one of the things that I think people are concerned about is, are we going to look at different strata around social determinants of health? And could treatments have different value to people who have different social determinants of health needs? And, is that going to be taken account when we're looking at the price negotiations for the drugs that will be included in the IRA? I think there's also some new value-based care models that are coming out. For example, the ACO REACH model that CMS has recently promulgated. And those are explicitly looking for health equity plans. And so they're hoping to have some accountability for documenting those health equity impacts, measurements, and outcomes. Hopefully that can help to start to address some of these unmet needs. And we think one of the ways that to do that is to measure what those are and to see how they're changing over time. And hopefully providers and others using these types of models can use this information not only to measure the unmet needs, but also to help tailor interventions in terms of screening and referrals or prescriptions for social needs like housing or food that I was discussing before. The National Quality Forum has recently started bringing some social determinants of health metrics in and coming up with some quality metrics around those. And so hopefully those will be rolling out and being used in healthcare settings in the real world very soon. And as I mentioned before, in terms of healthcare interventions, I think also for public health interventions, this type of data could be helpful to really think about where we should be maybe targeting our efforts to try to reduce some of these disparities. So I mentioned a little bit about health technology assessment, and IVI is an membership-based organization that's really about trying to raise the bar in how we do health technology assessment. And we became aware that health technology assessment really hasn't done much around equity or social determinants of health, hasn't really paid much attention to it historically. And so we've started a 2-year initiative. We're more than halfway through that initiative now, really trying to look at what can we say about health equity and social determinants of health in health technology assessment, and how can we pull that information into methods and practice and processes around health technology assessment to ensure that we're paying attention to these types of issues. And one of the things that we're trying to come out from this is concrete examples of things that we can do to center equity in health technology assessment, and come up with guidance and actions that people can take now to make sure that we're including that in our assessments. Also areas that in the midterm we should be looking to try to come up with better methods, better data, and better processes to pull that in. As well as some longer term initiatives that we know are needed around, for example, representativeness of data that's coming out of clinical trials. One of the things we've learned through this work, talking with various stakeholders, is you can't really talk about value without equity, and that to really talk about it, without bringing in these types of issues, we're missing things that are very important to patients and to the healthcare system. We've recently put out a publication from our initiative called No Value Without Equity. And if I can get my slides to advance, there we go. I believe this is in the handouts, so if you want to get a copy of this, and then there's the website here if you want to find out more about our initiative or to get involved in that initiative. So just some concluding thoughts here. We think that addressing health disparities is a critical component of advancing health equity, and that we can't really be doing this type of work and ignore these issues anymore. It really has to be brought in. And especially now that we have this type of data, we need to be making sure that we're integrating it with the other types of data we use, such as claims or EMR, to hopefully improve treatment access and outcomes for people who experience these types of disparities. We hope that people have seen ways that they could use this type of data in different settings to, help different stakeholders with their healthcare decisions, informing provider practice and performance measurement, increasing clinical trial diversity and helping out with recruitment of underrepresented populations, driving market access strategy to make sure that we're reaching all of the populations that are relevant, and assessing treatment coverage and reimbursement utilizing real-world evidence, again, to make sure that that people are getting access to this and that we're not causing health disparities to get worse as we put in new health interventions that we want to make sure that are getting to everybody in a relevant and timely manner. So this is my contact information. If you're interested in our work in this area or any of our other work, I'd love to hear from you. And with that, I think we'll now turn to questions and answers.
So as Sydney had said earlier, please submit your questions through the Q&A panel. And I think we have time for one or two questions. So Rick, why don't I start asking you one of the questions that has been in the chat, and that is, so how should social determinants of health or health equities be incorporated into health technology assessment?
Yeah, I think there's quite a few ways it can be incorporated. One is through formal analyses like the distributional cost effectiveness analysis I talked about before, which is really looking at how is this going to impact people at the low end of the scale versus high end of the scale, and are we going to cause more access issues because we can't get it to the right people at the right time. I have heard some people say, well, this social determinants of health stuff, that's not really I can't fix that. I'm just a healthcare provider. That's not, society's job. And I think to some extent that's true, but I do think we have an obligation to make sure that what we're doing at least isn't making things worse, that we're not broadening those issues. And so I think it can inform those types of things. I think one of the biggest things we've learned from our initiative is that it's not just about the data and the methods, but it's also about the processes of who you have around the table and who gets to help you decide what are the research questions, what are the things we're going to assess in a health technology assessment, what are the outcomes that matter to patients, and have those been collected in the data. And I think that's the other thing. This can help us identify, a truly diverse set of patients and patients who are often hard to get to those types of conversations to make sure that their voice is being heard.
Okay, I think we have time just for one more question before Sydney closes us out. Is there something in the chat for me, Rick?
Yeah, I think there was a question about do state Medicare, or I guess they mean Medicaid, require Z codes for determinative eligibility. I also wanted to ask, you brought up data security and privacy considerations. What are some of the things we need to think about in terms of those?
So yeah, so most linked projects are going to go through some level of requirements for attestation of, so that's basically saying that things are blinded enough that you're not going to be able to identify an individual within the population. So often some sort of written documentation is required, and you'll see even in data sets that are not linked, Medicare, you cannot report any N that's less than, say, 10 patients or 20 patients. You usually have to put in a star, or you may, a percentage, you might have to say just like it's less than 10% of, so that's some of the ways that you can deal with the privacy issues around, especially around linking data. And so let's actually, Sydney, I'm going to turn it back to you. We'll be sending out some answers via email to the other questions. But Sydney, you want to close us out, please?
Yeah, thank you both so much for your time today. It was really a pleasure to have you with us, and I hope you enjoyed yourselves.
Yeah, thank you.
In closing, we hope you enjoyed this HealthEconomics.com webinar sponsored by Magnolia Market Access, and I hope that you all enjoy the rest of your day.